Good afternoon, once again, and once again thank you to Marco for the kind invitation. So my second due today is to tackle with the problem of the ISGPF classification, International Study Group on Pancreatic Fistula Classification. Everything settled? Well, I just want to go also through the history of the problem from the very beginning. And thanks to the previous speakers, we have more time to understand what happens in the last more or less 10 years, I have to say, Bill. More or less 10 years, because our awareness about the problem started in the beginning of 2000 when we realized, together with other authors in the literature, that the rate of pancreatic fistula after pancreatic resection is depending on several factors. Last but not least, the definition you are going to use. And what we did in this paper, published in 2004, was to recognize, going through the literature, the 4 definitions that at that time were able to summarize the current pancreatic fistula concept in the literature at that time. And we recognized these 4 definitions from definition 1 to definition 4 that were the current concept in the literature and were ranging from, let me say, a very strict definition for surgeons, because if we look to definition 1, you can see that 10 cc per day from the drain as output was enough to consider this rich fluid of amylase from the drain since 4th day postoperatively or for more than 4 days as a fistula. On the other range of the 4 definition, you can find a different definition that is much more acceptable for surgeons, because you see that in this definition you need to have at least 50 cc per day instead of 10 of amylase rich fluid since the 11th and not since for the 4th postoperative day or for more than 11 days. Well, these 4 definitions were present in the literature, and what is very interesting to see is that if we apply to a series of about 250 pancreatic resection we did in 2 years in that period, you know, if we use the definition 1, the rate of our fistula is not far from 30%. And on the other side, if we use the definition 4, the rate of fistula is more or less 10%. So it is very easy to demonstrate that the definition you use is very important in terms of rate of pancreatic fistula in the post-operative period. So we became aware at that time that it was absolutely important to find a gentleman agreement among pancreatic surgeons around the world and to find together an international chapter definition in order to be able to compare our experiences around the world. So, particularly thanks to the European Pancreatic Cancer Study Group, the ESPAC organization, I was appointed to chair this international group of surgeons coming from all over the world. You see, Bill, that is here, was involved, Marcus was involved, Carlos Fernandez de Castillo and Fernandez Cruz, that is here, Dirk was involved. So all the authorities in pancreatic surgery around the world were involved. And what we try to do in 2 years of different meetings, of emails and discussion and so on, was to understand the terms. And this is very important. And today we can state that anastomotic leak or PAF, that is not a platelet activating factor, but is the pancreatic anastomic failure, are the underlying phenomena of the pancreatic fistula, and we are aware that in different countries these terms are synonymous. Then probably anastomic leak is preferred in Germany, in United States prefer the pancreatic anastomotic failure or dehiscence, but pancreatic fistula, anastomotic leak, anastomotic failure are the same, have the same meaning in our everyday practice. And we are also aware that there is a connection in between leak, failure, fistula, and collection, abscess, delayed gastric emptying, bleeding. The vast majority of patients who experience this complication has an underlying phenomena called leak, failure of the anastomosis, or pancreatic fistula. So this is very important because now understand better each other, even if we use different terms. So the second step in the job was to find a grading system. And it was not easy for all these surgeons around the world to forget academic approach, systemic approach, but to go with a very frank discussion to the everyday practice and to find and to try to find some grading that was the real mirror of the problem we have with our patient in the everyday practice. So we decided to grading the fistulas in a fistula that is a so-called biochemical fistula with no clinical impact, while the B fistula is a fistula in which we are in some way, independent of the reason, forced to leave the drain there, to wait days and days, sometimes weeks, before to remove the drain. This is what happens in our experience every day. Sometimes this problem happens much more in the left resection than in the pancreatic duodenectomy. But in this patient, we are forced to maintain the drainage or the drainages there. Whenever we have sign of infection in our patient and we are forced to use the radiological tools to understand what happens within the abdomen of our patient, and whenever we need to use specific treatments, particularly total parenteral or enteral nutrition to fit patients, or we need to use antisecretive drug, or we need to use antibiotics drugs to treat the patient. And of course, also in patients that have been originally discharged but come back to the hospital because of new problems arising. And last, we decide to have a C group of fistulas that are fistulas related to severe clinical condition, need of intensive treatment, need of intensive care, reoperation, sepsis, and of course that related to the complication. Well, in the same period, another group of surgeons chaired by my friend Pierre-Alain Clavien tried to apply another grading system to the pancreatic surgery using the same concept of the grading of general surgery complication. And the main problems they had to use the ABC system was that ABC seems to be too much complicated to these surgeons, and because of this they decided to have grade 1, 2, 3, 3A, 3B, 4, 4A, 4B, etc. So the proposal was a much more complex to apply with several points that are very interesting to discuss, but with some problems that are really very difficult to understand. For example, you can see that under general or non-under general anesthesia, is different in A or B, that it means that whenever you do an angiography to treat a patient with a severe hemorrhage, you have a minor complication if you have to reoperate, etc. So we had a lot of discussion about this, but you know, science is a very democratic way because the reader and the writers decide about who is wrong, who is right, and it is easy to understand because if you go through the web, you find that this attempt to grading the complication in pancreatic surgery received till last week a total citation index of 50, while the international study group achieved a total citation index of 278. So it means that this seems to be the basic system nowadays for surgeons dealing with pancreatic surgery to grade the complication after pancreatic surgery. And this approach to complication have been validated by different groups. This is the first group in Boston, the Beth Israel Medical Center, who tried to apply the system, and they found the system as a working system because you can see no clinical impact of grade A fistula as patient without fistula, and improving impact in terms of hospital stay, in terms of other complications related to patients, and in terms of total hospital cost. We recently worked to apply this international system in our institution, thanks to the work of this Greek lady, resident in our department. And what Desvina did was to look to 755 pancreatic duodenectomy carried out in 6 years, from 2000 to 2006. And you can see she found 147 patients who present different grading of fistula. 20% of these patients got a hay fistula with no clinical impact, hospital stay 11 days. Grade B was the majority of the fistula we had, no deaths with this fistula, 21 days, 3 weeks, conservative therapy or minimally invasive procedure in this group, and the number of C fistula was about 9%, 13 patients, and as you can see, we have 12 patients reoperated on, and a mortality rate in this group of 4 out of 13, sorry. And these 4 patients are the 4 patients who died in the whole series of 755 pancreatic duodenectomy. And much more interesting is the cost, not in American dollars, not in greens, but in euro. You can see this is 10,000 euro about the hospitalization cost for patient with no fistula. That is 11.50 in patient with a fistula, no clinical impact, no economical impact. So we are growing and growing to 25, 27, 26,000 euros till a very expensive number of money you need for treating the very severe patients. So everything settled here. Well, I think that what we need today is to better define the suspicion and the factors, the high risk factor for pancreatic fistula development. I think we need to better define the problem of the A fistula, and we need also to clarify, even if this is already done in some way, where patients treated by percutaneous or endoscopic postoperative drainage fit into, if group B or group C, and then to improve in terms of international sharing of data. Well, what I mean with suspicion, this is just to remind you that in the original paper published on 2005, we stated that the diagnosis may be suspected. This is, as I told you, what we tried to do together was to to go to our everyday work in the world. And what we felt and what we feel is that in the clinical course, we start to suspect the presence of a fistula, and this is based on different clinical and biochemical findings. The definition was very broad. We have any measurable volume of drain fluid with amylase content of more than 3 times the upper normal serum value. I will be back on this point. And it's very important also because this is the very everyday practice. We based our suspicion on the appearance of the output. I remember it was Charles Yeo that defined this appearance as a sinister appearance. That means the dark brown aspect, we say like Coca-Cola, okay? Or greenish bilious, milky Walker, and so on. And we have also associated clinical findings, pain, distension, impaired bowel function, and so on. And of course, fever, white cells, white cells, increase of acute phase phlogistic proteins. So we have still open problem. In my opinion, the first question is, what is the real meaning and the scientific background of the statement, drain fluid with amylase content greater than 3, 4, 5 times the upper normal serum value? And the second point is, does the drain fluid amylase content reflect pancreatic leakage and or the risk related to a pancreatic leakage and fistula development? And if yes, when? So we are now back to the previous problem just discussed, the problem of the drains. Drains yes, no, etc. Well, we have, thanks to the job carried out in our department in the last few years, I think some clues for a better understanding of the problem. And this is the paper published by our group in anal surgery, looking to the amylase value in drains after resection as predictive factor of pancreatic fistula formation. Well, the message coming from this trial was that whenever amylase value drain in the postoperative day 1 is more than 5,000, and whenever is more than 200 in the postoperative day 5, we have a high predictive risk for a pancreatic fistula. On the basis of this trial, we designed another trial, and what we did, we selected patients in which the amylase value drain in postoperative day 1 was less than 5,000, so in a very low risk of pancreatic fistula development. Well, this group of patients were then randomized on postoperative 3 in 2 groups. In one group, we apply, on the basis of the previous study, a fast-track surgery approach. We removed the drains. We started to give food by mood, and at the same time, we randomized another group of patients to follow the historical approach we have in patients who undergo pancreatic duodenectomy. So we delayed the removal drains timing to postoperative 5, 6. Well, these are the results that are of a group of patients with low risk looking to the amylase value in postoperative day 1. And as you can see, complication, pulmonary complication, abdominal complication, delayed gastric emptying, readmission to the hospital stay, and in particular, pancreatic fistula was significantly lower in the early drains removal than in the light removals, 2% versus 26%. So the multivariate analysis, the prediction risk factor of pancreatic fistula, when the risk of pancreatic fistula is low because it's under 5,000 units per liters, the value of the amylase drain in the postoperative day is the delayed removal of drains. So this is my personal feeling. The question is not to drain, yes or not, but the question is when to remove the drain. So amylase value drain in postoperative day 1 more than 5,000 is the only realistic suspicion of a pancreatic fistula. And the value more than 2,000 in the postoperative day is the only realistic definition of an A fistula. In low-risk patients, the delayed removal of the drains is a risk factor for the so-called late pancreatic fistulas. So in this way, I think we are going to better define the suspicion, and we are going to better define a fistula in the next future. The third point was to clarify if patients treated by percutaneous endoscopic drainage fit into B or C group. Well, I think the answer is already done, because if we go through the literature, and Bill Traverso was the first man to show this, there is no difference in terms of hospital stay in patients who underwent transcutaneous or endoscopic drainage of fluid collection compared to patients who didn't have this particular complication. So we can consider today this approach as a mini-invasive approach, as a minor complication if compared to the complication we have in patients that must be transferred in intensive care unit under mechanical ventilation. They need to be reoperated on with a classic approach, etc. But now we need to improve our international sharing of data. So I think that now the problem is not the everything settled, but everything is in Seattle, because Bill Traverso is the main responsible man of this web-based calculators that he has already shown. You can find it in the Pancreas Club web, and this is a determinant factor to use this in a consensus definition based, and use this to understand what happens in our hands and what happens in terms of international sharing of data for our common academic needs. So this is the criteria already shown by Professor Traverso. I think that we have to look for the future to this point, the red point, because I feel that we need also to know what happens in your hands in the first day as regards the amylase value in drains. It's easy to apply, it's very fast to apply, you have not to spend a lot of time to do this. And Bill has already presented this data, so I'm not going to lose time to show you that it seems to work, and he will be back on this, I think, later on. So let me go to my conclusion. Everything settled? Well, I think that the system we have published in 2005 is the mainstream to follow. We need to better define the suspicion of pancreatic fistula and the high risk condition. We are aware about the soft pancreas, the diameter of the virsum, but we must be aware that also the management in the post-operative course should be, in some patients, dangerous and responsible for the pancreatic fistula development. Today, I think we have data for better defining a fistula, and particularly at this point is important. Elevated drain amylase means that you have to differentiate patients with less than 5,000 on the first day, because these patients are good patients to fit into 1 week, 1 Whipple policy. 1 week, 1 Whipple means that nowadays more or less 50% of our patients are able to go home in 8, 9 post-operative days, because the early removal of drain, as already stressed also by other authors, in this patient is we delay the removal of drain, we put this patient in high risk factors for pancreatic fistula development. In other patients, of course, we have to wait, we have to delay the removal of drains, and to look to value in the post-operative 5. If the value is less than 2,000, this group of patients are patients that didn't experience pancreatic fistula, and the drainage can be removed. But if the amylase value is still high, more than 2,000 on day 5, you have to wait and see, because you have an A-grade fistula, and this grade of fistula could be moved to a grade B or C fistula in the post-operative course. So we must be very careful in this patient, in the decision-making. Probably we need the help of a radiologist to understand with the sinogram or with the CT scan, depending on the patient condition. The B group means also patients with minimal invasive procedures, and of course it's clear what we mean with grade C fistula. So please use the Pancreas Club web, because we all need data, and you need data in order to be aware about your results. And this is the web you have to connect with your computer. And please look to drain amylase value on first post-operative day, and confirm or not confirm the Verona team post-operative management data. And last, following this way, we will be able to design pathways for fast-track policy and for correct pancreatic fistula grading, prevention, and best treatment. Thank you so much.